Hi, my name is Dr. Steiner, as many of you know, and I'm making this video to discuss our existing and somewhat new also aspects of our narcotic policy. We have gotten more involved as of late with narcotic prescribing for many of our pain management patients. I think due to the times, and at the same time I think it's important to discuss with many of you some of the aspects that we are seeing within the overall environment that are coming largely from the government regarding issues that we're facing as a country and as a people with narcotic usage. Narcotic usage can be fraught with a variety of potential dangers, and that is why it has been a controlled substance and is why it's coming under increased scrutiny. We're seeing day to day more and more information coming our way from your insurance carriers, from the government, from the Department of Health regarding the safety or lack of safety of narcotic usage across the board. These are not referring to problems necessarily with people who are abusing or selling, although that's also an issue, but really with people who are being prescribed medication and are running into difficulties that I think are adequately being addressed by a lot of practitioners. To the extent that could or would be true, I want to discuss with you some of the issues regarding the problem and to talk with you about some of our strategies and some of our rules and policy. Number one, let's discuss one important fact, and that is this here. Can you all see that? That is the number, yes, 17. 17 is the times that drug death, accidental drug death, has increased since approximately 1999 through 2008 when it was measured. This is astronomical. So if we were talking about 1,000 people back in 1999, we're talking about 17,000 in the U.S. alone. We're talking in 2008. Again, it's believed to be higher this year than last. It's increasing. This is not drug dealers. This is not necessarily drug abusers. These are people who are using the drug and are running into difficulty, usually unexpectedly. And many of the problems fraught with narcotic usage stem from not being anything more than trying to be a very good user, running into issues of what are referred to as tolerance. That is to say that the same 20 milligrams of, let's say, OxyContin or oxycodone that helps you today will not help you in a month from now or 6 months from now. It just can't. The receptors are such that when you go to use that drug, it is more difficult for that drug to have an effect. So one must increase the dosage to get the same relief. There are so many deaths at this point from opiate use in the U.S. alone that for the first time ever, I believe it was last year, opiate deaths, accidental opiate deaths or narcotic use in opiate cases, not heroin, not drug dealers, actually was beyond the rate of those in car accidents. So more deaths from narcotic use than from car accidents. That is pretty sobering. More dangerous to use these drugs even under a doctor's care than to go ahead and be in a car. Now, there are a few caveats that they discuss when dealing with these issues that are rather important to understand as guidelines. One of the things is 6 to 12 months. 6 to 12 months of use is considered to be about the most acceptable use of narcotic for non-cancer pain. If somebody were to have cancer, obviously it's a different story. All bets are off. We're not discussing use of opiates in the setting of cancer pain. Those scenarios tend to involve malignant pain, malignant cancer, where the patient is anyway heading toward a very nasty ending. Even if it's a non-life-threatening or non-terminal cancer, again, cancer can be different. It's established already, and the opiates don't necessarily have the same level of danger. Again, there are rules for that. But the majority of cases we're discussing, at least in my practice, and if you're a new patient, perhaps that's different, would be non-malignant, non-cancer pain. So 6 to 12 months is our rule of thumb in terms of how long would be the longest we'd want to consider using this. The other rule of thumb is 120 milliequivalents of morphine. Now that's not necessarily what you're on, but it's a conversion factor for almost all opiates. 120 milliequivalents of morphine for many in this practice would probably be more understood as 80 milligrams of oxycodone, which would be OxyContin, roxicodone. 80 milligrams would be just one pill of 80 milligram OxyContin, that is the beginning of the major danger zone. It's not really a once daily product as OxyContin, so no one really should be on OxyContin 80 once daily. They would be on 40 twice daily, 80 twice daily. These are already approaching and beyond what I would always tell people is the major danger zone. You consider that most people are going to be on narcotics such as that, and also breakthrough narcotics such as roxicodone with OxyContin. It's very likely that a person could be many times beyond the what I would refer to again as the major danger zone. The other additional point I would say for many of my patients, so you understand, is that being with any other sedative in this setting is also extremely dangerous. So if you're on a sleep product like Ambien, if you, for whatever reason, would need something such as Xanax or Valium, that also is going to be a major issue. Part of our response to all of this is to offer patients the following, which what I would call a good clinical practice scenario. We are more than happy to address pain. That's what I do for a living. But there are many approaches to pain, many of them non-opiate and non-narcotic. We are going to favor non-narcotic solutions all the time. We have great success with non-narcotic solutions. We're talking about medication that's not narcotic, chronic pain agents, acute pain agents that are non-narcotic, not fraught with these dangers. We are also talking about various other techniques, therapies, physical therapy, acupuncture, chiropractic care, biofeedback. We're talking about interventional pain management, epidural steroids, facet blocks, and of course surgery. If someone comes into this office with an arrow through their head but wants opiates to help their pain, I certainly might suggest maybe we want to remove the arrow. Not that I'm an advocate of surgery in all cases or even any cases, but certainly there are appropriate settings where that would be reasonable. Every patient who walks through here needs to have at least a diagnostic workup at some point having been done that we have a record of, or that we perform, that explains what the pain's coming from, so we can offer some solutions tailored for your situation. We also need to apply a treatment regimen that makes sense. Safe use of opiates would therefore dictate that if you are thinking of needing an opiate, then the most we would want to do is use it as a last resort, and certainly within the confines of these limits. If you are already on an opiate, which I know is the case with many of you, and we are in and above and beyond these guidelines, if you're either on a benzodiazepine, which would be a Xanax or a Valium, if you're taking more than 120 milliequivalents of morphine or the 80 milligram OxyContin per day, or you've been using meds for more than 6 to 12 months, we have to really discuss where we're going with this. I certainly, as a practitioner, don't feel very comfortable going on, closing my eyes and saying, well, here you go. And as I often tell my patients, it's not even you or myself that I'm afraid of. I'm always, I certainly want what's in your best interest and what's in your well-being. But, you're talking about an accident happening in the form of something very simple. These drugs have side effects. These drugs can cause respiratory depression. The classic example I give people is you go out on a Saturday night to a party, you have a drink. These days, not that I advocated people do a line of coke, God knows what, you go home, you take one of your 80 milligram OxyContin because now you were dancing and your back hurts, you double up on the Roxy. What are you doing wrong, right? So the problem, however, is that OxyContin plus Roxy, you just took 140 milligrams of roxicodone and you had alcohol and you're tired and you danced and your heart's going crazy and you did some cocaine that night and suddenly you don't wake up the next morning. Or I get a phone call from the medical examiner that they find a bottle of yours, near the bed that you're no longer alive in. We joke that's happened with 3 times in the last year within this practice in various settings, and I'm not even clear that we had anything to do with the death, that it was involved with our medication, but there is that strong possibility. It is sobering. We're talking about 30 and 40-year-olds who are in pain, who are legitimately having problems. We need to both work together to find safe, reasonable solutions. I'm offering all of my patients a variety of options. We certainly are most interested in trying to work with all of you toward finding safe options, clarifying diagnoses, and then moving ahead on a treatment option that would be a way to move off of the current narcotic medication with a way to build up initially with non-narcotic options and try to do substitution. Over the course of time, move you more toward non-narcotic and help your pain that way with possible definitive solutions. There are two other obvious options that are beyond this. If you feel that your problem is a real problem, and we can be honest that one of the reasons 120 milliequivalents is deemed the top dose that one should have is that it's felt that beyond that point, we're no longer really in the realm of pain control. That if it's not cancer pain, we are probably feeding a dependency or a tolerance issue, meaning now we have a problem with the drug, not your pain. I understand that you're in pain, but that's going to be because the medication just can't help you like it did yesterday. We're going to have to find alternatives. There will never be enough narcotic to keep you on for the rest of your life to always satisfy you. It just won't exist. This is always going to head down a bad path, which is why its use has to be limited time-wise. Above and beyond that, one could certainly explain to us that we can talk together that they have an issue and a problem. We're happy to give you information regarding centers that specialize in helping you come off of this stuff and help your pain, whether it's an expert pain management center above and beyond the scope of what we can do here, or a facility that works on detoxification, helping you get off. We are not a detox program. When we give methadone in this practice, it is for pain control. And even with these medications, we're not in a position to help you detoxify. We're in a position to help you find alternatives for your pain. If above and beyond that, you tell me that you're really just not interested in following these rules, that you understand where we're coming from, but you feel you can do this safely, again, I will kindly and strongly disagree with you, but we're not here to hurt you, we're here to help you. We will help you find an alternative pain management specialist. We can provide you with names, and we will, with people locally and people more distant who would be able to address your pain management needs in a way that you might feel more comfortable with. However, I'm going to give you a caveat that just understand, I really highly doubt you're going to find a reputable pain management person who's not going to pay attention to these issues. It is an important thing. We are ultimately out for your best interests and welfare. It's important that I want to make sure that every patient and person understand this. God forbid if a problem happens, realize it's one of your loved ones will end up here yelling at myself, wondering why I was irresponsible and went ahead and gave you narcotic, why I didn't exercise control, why I didn't explain the issues of safety. We're not going to let that happen. We're going to make sure that every one of our patients understands the issues involved here, and we're also not going to go ahead and actively give any medication out that we don't feel is in the realm of safety, is in the realm of respecting good, safe clinical practice and narcotic usage. This is just an explanation of the background. I will be in to discuss with you in person or one of our practitioners a more comprehensive solution for your particular problem. But again, we are not forcing anyone, nor will have any malice for those who feel that they want to move to another program, who feel they need a different practitioner. We're offering that option very happily. We're just telling you what we feel comfortable doing and what we understand to be the safety issues. I thank you very much for your time. We will talk to you in person shortly. Thank you.